If let me just slow down. I am talking to stop, let me know to speak up. If my Kentucky twang is coming out, you're like, what did you say? Or what is that? Then you let me know so I can repeat myself. But we are gonna spend the next 4 days talking about infectious disease. And I believe that you are doing antibiotics, and I think you start anti-parasitics and maybe some antifungals today in class. So hopefully all these things are kind of coming together for you. There's a ton to cover. Unfortunately, we are not gonna be able to cover everything. We're not gonna be able to cover everything down to the minute detail either. But fortunately, you've seen a lot of infectious disease. You've seen it in peds, you've seen it in GYN last semester, you've seen it in a lot of lectures. So hopefully some of this will be familiar and more of a review. Your objectives are on Blackboard. I'm not gonna go over those today. My goal for this course is to basically help you think from a clinical mindset. I don't plan on going deep dive into pathopharm. I don't plan to go deep dive into the actual drugs themselves, but we will talk about treatment. So the other classes will hopefully kind of supplement that for you. Just like your OSCEs, those labs that you have, we're talking about how does this patient get this? Who's being affected? How are we going to treat it? How are we going to confirm this diagnosis? How are we going to prevent it? So these are the things I want to think about when we're going through these different diseases. I'm going to try to do most common things that you'll see, but we do have to go over rare things just because they kill people. They're debilitating. So we have to go over them, even though I suspect you probably will not see them in your lifetime. You will read about them, but you probably will never see them unless you maybe do some international type travel. You might see some odd things you just don't see here in the US anymore, but we are going to I'm going to try to focus a lot on what you're going to see on your pants as well. The pants says infectious disease is about 6%, but it's probably double that. It's probably 12% because it's everywhere. It's going to be in your palm. It's going to be in other organ systems. It's going to be in derm. So you're going to see the infectious disease in other places. So in reality, it's probably about 12%. I'm not going to try to reteach you things you've already learned. We're going to just kind of review those, if that's okay. Current with your friends. There are lots of sections that cover infectious disease, so use it as you need to. Go back to your lectures as you need to. In my lectures, if you were to go through the slides, you'll see at the very end some resource slides. For most of those, they're just for supplemental learning, just so you can deep dive into a topic if you want to. I probably will not test you on these things. That's just a way I was able to like take some of the slides out that we were actually going to talk about in class. So you need to look at those. Feel free. Due to the volume of the information we're going to go over, I'm going to try to answer as many questions as I can, but if I am unable to get to them or we're running low on time, please email me and I'll try to answer them in 24 hours. Okay. All right. So what is an infectious disease? Infectious diseases have been plaguing us throughout history. They go back a long time. So we want to start with the definition of infectious disease. These are illnesses caused by germs, such as bacteria, viruses, fungi, parasites, prions, different things like that, that enter our body and multiply and cause infection. Some infectious diseases are contagious, or what we call communicable. So you're able to pass them from person to person, just like COVID, which we are having a little increase in some of your classmates, a lot of students on the campus are sick right now. So definitely take heed and wash your hands and do what you need to do to stay safe and healthy. Some infectious diseases can be spread by germs carried in the air, water, food, or soil. They can also be spread by vectors like biting insects, mosquitoes, ticks, things like that. So we have a chart here. This is from the World Health Organization. This is the latest chart I was able to find with the top 10 causes of global death. And you can see it's from 2019. So it's probably not the most up to date, but even then you can see that infectious disease is still a leading cause of death worldwide. It is in the top 10, number 4, lower respiratory infections, 5 neonatal conditions, and that's including neonatal sepsis, neonatal infections, but it also bundles in preterm birth complications, birth trauma, and things like that. Down at number 8, you'll see diarrheal diseases. So we definitely want to be mindful of the causes of death that we have here. HIV and TB are no longer on the list. They have been in the past, but those have decreased over time. They're still a leading cause of death in low-income countries, as is malaria, but they're just not in the top 10 anymore. And we all are familiar with COVID as well, which in the US was number 3 for top causes of death in the past. And I think in provisional data in 2022, it was at number 4. So definitely, we're familiar with this. So we're gonna get started. We have different causative agents, like we said during our definition. I'm gonna start with bacterial diseases. There are a ton. These are just a few that we'll kind of go over today. Acute rheumatic fever, botulism, chlamydia, cholera, diphtheria, gonococcal, you are familiar with as well. Salmonellosis, shigellosis, syphilis, tetanus, and there are several others on the agenda. So we'll get started with group A strep. Strep is also known as group A beta hemolytic strep or Streptococcus pyogenes. So we know that this is a chain. You see the chain structure around bacteria. To help you kind of remember pyogenes, you can break the word pyogenes down. Pyo meaning pus. And then if you look at gene, you can think of generation, formation. So a pus generating type of streptococcus. Not that they all do, but that's an easy way to kind of remember it if you're trying to differentiate between what type of strep is causing what in perhaps a case or intervention. Group A strep is the cause of a variety of infections. And we know that it typically affects the throat and the skin. You should have learned about group A strep in peds. We talk about strep pharyngitis, tigos, fever. These affect millions of people, so I expect that you'll see quite a bit of this in practice. Can anybody tell me how sore throat, how strep throat will present in the office? Outside of the sore throat, what other symptoms might a patient have with strep? Fever? What else? What is that? Hurts to swallow. Anything else?
But they sometimes get like little red spots on the back of their throat.
Red spots in the throat, Abel? Lymphadenopathy, yeah. Another one for peds. Can anybody think of one that you might see specifically in peds? I hardly see it in adults. Ash, the one I'm looking, vomiting, yep, it's GI, like stomach aches. They complain of a belly ache, sometimes even before their throat is sore, like their tummy hurts. That's what I've seen a lot. And I believe everybody knows my background is ENT, so I do see a lot of ENT things. So we definitely see that quite a bit. Impetigo, we remember that that is those honey-colored crusts. Honey-colored crust, the pants is going to go over that. That's gonna be on your pants. Honey-colored crust, you wanna remember impetigo for that. That's that stuck-on appearance around the mouth, and it is quite contagious. Again, these are more commonly seen in pediatric patients. We're not gonna go a deep dive into that. Scarlet fever, what do you remember about scarlet fever? It occurs a couple of days after the strep. Most patients will present with a sandpaper rash. That rash blanches, it might be red. It does not affect the face, the face area around the mouth though. So there will be circumferential pallor. The tongue has that strawberry effect. And then there are pasty lines. Does anybody remember what those are? The creepy both, yeah. So axillary, inguinal, red streak type, presentation that you'll see with that. The first time I saw scarlet fever was not in ENT. I did ENT for 13 years. I've never seen scarlet fever in my practice as a PA in ENT. I saw it in my peds rotation. And the patient had come in, they had strep, and the physician said, do you know what this is? And I said, thinking it's strep or, resolving strep. He said, feel his arm. And I rubbed it and it was funky. Now, the patient was African-American, so it wasn't red, wasn't very obvious. You couldn't even hardly see it, but when I rubbed, I could feel it. And it felt like little bumps, right, running under my fingers, like a sandpaper rash. So definitely it happens, but I've only seen it, once, and that was in peds. So definitely be on the lookout for that. The treatment of choice is penicillin. Who knows what class that's in, you'll test tomorrow. You like data. So data like film, good job.
Here's favorite word.
All right, so group A strep comes in just for general group A strep, which are like milder illnesses. And then there's the invasive form. Now, this is the more severe end of the strep. Do you have a question?
Yeah, sorry, just to go back, so scarlet fever treatment of choice is penicillin, but it's also the treatment of choice for strep.
Yes,
So if they're being treated with strep, they shouldn't get scarlet fever.
they should not. Yeah, you want to make sure you treat the strep. This is the underlying cause of the scarlet fever. He's not responding well, maybe you need to change your local treatment. But yeah, it should respond to that. So the second group are the invasive. These are more severe, like we said. These tend to invade deeper tissues versus like your throat or your skin on the, in terms of like a scarlet fever. So these are the necrotizing fasciitis, toxic shock syndrome. These are the big, bad, scary, the uncommon forms of strep that you might see. The media likes to call necrotizing fasciitis the flesh-eating bacteria. So, it's not a fun thing to have. And most patients, if they get it, usually have had some type of surgery or they have some type of open wound that the infection is able to break through. It could be from a bug bite too. So it could be something as simple as a bug bite or injection drug use where there's an opening in the skin or a break in the skin. Necrotizing fasciitis, typically these patients present with red, warm, swollen areas of skin that spread quickly. And that pain is severe and it's outside of that area of redness. So maybe they have a spot of redness, but their pain is going all up their arm or all up and down the arm. So you're gonna see it's like outside of what you would expect. There could be areas of redness, gangrene, and necrosis. Typically, these patients have to have some type of hospitalization. You're admitting. If you see this, you're admitting. They're going to the hospital. They need some type of surgical exploration and antibiotic therapy. And you can see that progression of necrotizing fasciitis. I just want to screen. So it can get pretty bad. This can lead to sepsis and people die from it. So it's to be taken serious. Staph aureus and Vibrio, which we'll talk later, also can cause the necrotizing fasciitis. So it's not just strep that can cause this condition. Toxic shock syndrome, the same, can also be caused by streptococcal species, but can also be caused by staph. And the staph is the more common of the two. So it's unlikely that you'll see streptococcal toxic shock syndrome, but it is possible. These people will present kind of like a mild fever initially, or mild, viral condition, fever, chills, myalgias, nausea, and vomiting. But then within like a day or two, they're going to develop a very quick pain, low blood pressure. Then it just goes really, really fast to multi-organ failure, and even possibly death. These patients may have tachycardia, they may be tachypneic. It's pretty serious as well. So this is another stat hospital need to go to the ER. They'll need IV antibiotics, they'll need fluids, and they may need surgery depending on what kind of, if they have any type of skin, sites that need to be cleaned or taken care of. Toxic shock can also be a result of minor injuries, surgery, chickenpox. So that means varicella or shingles can then progress into the toxic shock syndrome. So that's something to be mindful of. And then you have post-streptococcal glomerulonephritis. This is not part of that invasive group. This is just another condition that we see with group A strep. Again, not very common. I believe you saw this last semester. Not for sure if Dr. Liddell caught that, but I do remember you all going over that. These patients present with hematuria, swelling in the face, eyes, hands, or feet, and fatigue. This is a rare kidney disease, so we're not gonna spend a lot of time there, but I do want you to be aware of it. It does happen after group A strep. It can happen after impetigo. It can happen after a strep throat. So you wanna be familiar with that. One way I like to remember, post-streptococcal glomerulonephritis, which I'm not for sure if Dr. Brazil taught you that. Sore throat, pea coke, face bloat. You've heard of that mnemonic. Sore throat, they have, maybe have strep. Pea coke, their urine is dark brown, reddish, and then their face bloats because they have the swelling on their eyes. So that might be a way to help you kind of remember that. This usually occurs about 10 days after strep, but several weeks after impetigo. So that kind of helps you differentiate that. And your differential is Berger's, the IgA nephropathy, which also presents with T-colored urine. So you'll need to be able to weigh those two out. And one way to do that is that the post-streptococcal glomerulonephritis is gonna happen later. The IgA nephropathy is gonna happen a little bit faster. So think post being late in terms of presentation. So we'll get started with acute rheumatic fever. Did you all go over this in peds with Professor Rogers much? Yes. Okay. So when you think about rheumatism or rheumatoid arthritis, what are you thinking?
Autoimmune.
Joints, yeah. Joints, pain, inflammation. So when you think about acute rheumatic fever, I want you to think about inflammation. This is an immune response to group A strep. It's not an infection, it's not contagious. So this is more of an immune response, like an autoimmune disease. Most cases are due to undiagnosed pharyngitis. These patients are possibly in an area where they lack access to care. They thought they had strep, they just let it go. They didn't go to treatment, or they were inadequately treated for strep. So maybe they had a 7-day course of antibiotics and they decided to just take 2 days. And then you have the result of acute rheumatic fever. It can affect the joints as well as the skin, nervous system, and heart. The heart involvement is the most dangerous. That is what can lead to rheumatic heart disease, and that is what kills people with this condition. So who would be at risk? Patients age 5 to 15, not very common after 40 years old, not very common before 4 years old. This is going to affect people in crowded areas or those living in poverty. And it would typically be more present during the winter and spring. And why would that be? Why would you think, Shaq? Want to think about strep. Strep is more common in the winter and spring, so you may have more acute rheumatic fever during that time. Again, this is not contagious. Is the strep contagious? Yes. The acute rheumatic fever is not. This is not to be memorized. This is just for you to kind of understand that this is not very common here in the U.S. It is worldwide, seen more commonly in Australia, sub-Saharan Africa, where there's overcrowding and lack of access to antibiotics and things like that. If you see this in a patient here, your STEM is gonna say, this patient came from Hawaii to see you, to be something. Patient, from the American Samoa was into your practice, on an international trip or whatever, something like that. So, for whatever reason, it seems to affect those more. I tried to find reasons why, but I didn't really find a lot of detail on why it affects those patients. There seems to be some type of M-type thing that they're studying, but it's not very well known why it affects them so much. All right, pathophys, this is Professor Newman's part. We're gonna briefly talk about it because I want you to understand the autoimmune response. But we're not gonna go into it deep. I did leave something in your notes for you to look at. But basically what happens, group A strep, you're gonna get strep. It's gonna bind to the pharyngeal epithelium in the back of your throat. So your bacteria has an M protein on it. That M protein is the virulent factor. That is what your immune system is like. I'm gonna get you, I'm gonna kill you. And so your body creates B cell antibodies and it activates the T cells to go after that bacteria. But the M protein on the bacteria of the strep look like proteins in your heart, in your joints, in your central nervous system, and in your skin. So basically, when it's going to attack the M proteins on the strep, it's also attacking those other organs. So that's what they call molecular mimicry. You might see that, you might not, but molecular mimicry, it thinks that it's attacking the bacteria, but it's really attacking itself. They're attacking your own organs. So that's kind of how that works. It's a cross-reactivity. This causes a variety of conditions in those areas where the proteins are found. So your heart valves, your joints, your brain, and your skin can all be affected by acute rheumatic fever. If my body's attacking itself, it's more autoimmune versus infection, right? So does that make sense to everybody? So what are the signs and the symptoms? So typically, this infection will start about 2 to 3 weeks after the infection, but it really can range anywhere from 1 week to 5 weeks. There usually has to be a history of a sore throat. So they at some point had a sore throat, and then all of a sudden they presented with these other symptoms. But patients will come in with fever. 90% of patients are gonna have fever. 75% are gonna come in with arthritis, and that is the most common presenting symptom. Not the strep throat. Oh, they had strep throat a couple weeks ago. They're coming in because they are having painful they're having joint pain. And it is a migrating polyarthritis. So basically it's going from, oh, my knee hurt a couple days and then it went away. Now my elbows hurt, now my wrist hurt. It's like this migrating, spreading type of polyarthritis. And that's what most patients with this are gonna come in with. 50% of them are gonna come in with carditis or some type of heart issues. That's the only manifestation of this condition that is life-threatening. This is the most serious symptom, but only 50% of patients will have some form of carditis when you are examining them. 30% will have Sydenham's chorea, which is a late presentation, a late symptom. As you can see, this little boy, this little twitching motion, it's a spasmodic involuntary movement of the face, tongue, and upper extremities. It can happen in the feet too. I've seen it in the toes in studying, so it can happen, but it's just kind of that twitch. When you see chorea, you think choreography. So it's a dance. They also call it St. Vitus dance. It usually happens more in girls, but as you can see here, it's happening in a little boy. This is a neurological condition, usually it's self-resolving, it's self-limited, it goes away without treatment most of the time. But when you see chorea, they sometimes call that chorea minor, Sydenham's. That is different than what you might see in Huntington's. Huntington's also has a form of chorea. That's a major, chorea major, this is chorea minor. So Sydenham's chorea. Less likely subcutaneous nodules, firm, tender, often seen on extensor surfaces. This is usually something that we see with the patients who also have some form of carditis. And erythema marginatum, which is less likely, a less likely symptom as well. It happens in 6%. This is non-itchy, non-tender. And as you can see on the bottom picture, these patients have a lesion that is clear in the center with a raised edge. Usually occurs on the trunk and the proximal extremities. So when you look at erythema marginatum, remember it's a margin. When you think of a margin, you think of border. So remember that, so you can kind of think about that to help you remember that. All right, let's talk about the carditis because this is the most serious manifestation of the condition. So we talked about the inflammatory response. See if I can get this pointed away. All right. So you see those tiny little vegetations. There. So those tiny little vegetations are part of the inflammatory response. So what happens, the heart is inflamed and that inflammation causes those vegetations to form along those lines, along that line of closure. And it is an autoimmune destruction, most commonly affecting the mitral valve. It can affect the aortic and tricuspid valves, but more commonly, you will see mitral, and on your test, it's more than likely gonna be mitral. So if you have those vegetations on the closure and they're bumping into each other, what would happen? The valve, is it gonna close all the way? No. And what does that result in? Regurgitation, exactly. So our bodies aren't, excuse me, if our own bodies weren't causing this destruction, it would just be endocarditis. But because it's an autoimmune issue, it has to be treated differently and it has to, you have to diagnose it differently than you would endocarditis. Does anybody remember what kind of murmur you hear on mitral regurgitation? Solid. Heard best on the nerve apex, radiating to the axial area. The inflammation of pericarditis, of the carditis can involve other structures, so the pericardium will be affected. This is a pancarditis, it's gonna affect all three levels. The pericarditis is going to possibly cause a pericardial effusion. The inflammation that occurs in the pericardium leads to formation of fibrin deposits. So those fibrin deposits cause the layers of the pericardium to get sticky. They stick together and they affect the way that the heart moves, and that can result in a fibrinous pericarditis. If you have pericardial effusion or a pericarditis, you would possibly get a pericardial friction rub on that exam. These patients may also have a prolonged PR interval on their EKG, as well as cardiomegaly or heart failure as long-term consequences of the severe damage to those heart valves. This is another slide that just shows how the acute rheumatic fever affects the heart. I'm not going to go into detail because we've already talked about it, but I did want to bring it to your attention because of this little word down, this little section, myocardial ash-off bodies down at the bottom. That sometimes is a buzzword you might see in a STEM. And basically what those are basically immune cells that kind of clump together with other inflammatory components, and they affect those various layers of the heart and cause the conditions that we just talked about. So you may see it, I don't want to say it's top of the mind, but it is a buzzword for acute rheumatic fever, myocardial ash-off body. So I did include that because of that one little section, but we kind of already talked about that molecular mimicry and how that works. Yes,
How bodies be on histology of the
yes.
diffusion after or something? How are they, what would they be getting?
If they had to, yeah, so it's a histological, when they would have to go in there, I don't know, unless you had to have some type of procedure done. But it is a histological hallmark. So the diagnosis, we talked about how they present, and that is how you make the diagnosis. This is something you have to know. It is Jones criteria. Jones criteria, Jones criteria, Jones criteria, that is going to be on your test. You have to know Jones criteria. And what is Jones criteria? That is two major manifestations or one major and two minor manifestations. Now, this changes. There are different Jones criteria subtypes based on the area that you live, like if you're in a low income country or if you have different things. And there's a resource at the very bottom that you'll find. But for purposes of this class, purposes of your clinical practice, purposes of the pants, these are the criteria that you want to learn. Two major manifestations or one major and two minor manifestations. In most cases, these patients are also going to have some evidence of recent group A strep, positive throat culture, rapid strep antigen tests, elevated streptococcal antibodies. They have to have some type of evidence that they've had strep. So Jones criteria, this is an easy way to remember it. Jones, J is for joint. Painful, migratory, polyarthritis. You're gonna replace the O with a heart. That's your carditis, hand carditis. Three layers of the heart. The N is for those subcutaneous nodules that you're gonna find on the extensive surfaces. The E for erythema marginatum, and the S for the Sydenham chorea. Those are your major manifestations. The minor manifestations are more non-specific. That's fever, joint pain, increased CRP and ESR, inflammatory markers, glucocytosis, and a prolonged PR interval. So you have to have two major or one major and two of the minor. Now, when you do this, the tests are, when you're trying to decide what's major and what's minor, if you have joint pain, you cannot use joint pain and the migratory arthritis from the major. You can't use those together. Same thing with the PR interval. You can't say the carditis and the PR interval are both one. It has to be one or the other. You can't use both of them when you're doing that criteria. So again, the resource for high and low risk populations are at the bottom in your resources, but for testing purposes, for your clinical purpose, this is what you want to know. Two major plus one minor, or one major and two minor. Questions about Jones criteria? Differential, a bunch of things. Rheumatoid, osteomyelitis, endocarditis, lupus, sickle cell, malaria, could be a ton of different things. How are we gonna test? If you do a throat swab, more than likely by the time they come in, if this is happening 2 to 3 weeks after strep, you probably are gonna get a negative throat culture. But you could do some streptococcal serology test, like an anti-streptolysin or an anti-DNA test, if you need to kind of confirm that strep presence. Basic CBC, CRP, and ESR, echo, EKG, chest X-ray, just some of the different things you might order if you're suspicious about this. Again, this diagnosis is made by Jones criteria. Even if you didn't have all of these things, you had two major and one minor, or one major and two minor, you can diagnose acute rheumatic fever if there is some type of history of strep. So the treatments, you have to treat the underlying strep. Yeah. Okay. If you had a patient with a new onset of murmur, you would definitely want to, go through your testing. But yes, you could use that as part of your, or if you did an EKG and then a first degree block, you could use that. You could. So we said we want to eradicate the streptococcal infection. We want to treat that underlying strep. That is how we take care of acute rheumatic fever. These patients are going to get IM penicillin. Again, that is what type of drug? What type of penicillin is iambenzophine. Is that a aminopenicillin? Could you see it?
It's like two people answered. Also.
Oh, God. The arthritis, usually responds really well to high dose salicylate. The migratory arthritis observed generally responds in a few days, or weeks. Even if you don't treat it, it's gonna go away by itself. The studies have shown that corticosteroids, a lot of providers use that in severe carditis, but there is no proof that it is minimizing that carditis or that it's preventing it. But some clinicians do use a tapered dose over 2 weeks. It does help with joint symptoms, so that is an option you can use for patients that are in significant pain. Like we said earlier, the chorea is typically self-limited with bed rest, but there is off-label use of anticonvulsants that you can use for that. Again, for these patients, you do not want them to continue to have that immune response. Their body will continue to attack those valves, and we want to prevent that. So for some patients, they will also need to be on long-term antimicrobial prophylaxis. They will be on they'll be on penicillin. So that's something to remember. If you're given high-dose salicylates, and remember, this occurs in what age group? 5 to 15. What are you worried about? I heard it. Syndrome. Yeah. You gotta be worried about that. If you're giving aspirin to kids in the high doses, that's something you're gonna need to weigh those benefits. Okay. They have.
Just instead of like, kids,
Because they tend to respond better to that versus the ibuprofen for some reason. So there are providers that have taken it, but you do have to weigh that risk. Prognosis. Initial episodes may last months in children or weeks in adults. Persistent carditis, we talked about that. Cardiomegaly, heart failure, pericarditis, those are poor prognosis. So we want to prevent that. That's why we want to treat that underlying strep. We want to try to get this taken care of as soon as possible. Unfortunately, 30% of children affected die within 10 years after that initial attack. Again, don't think you'll see much of this here, but so you just want to be aware of it. All right, question. In the context of the Jones criteria for the diagnosis of acute rheumatic fever, which of the following is not considered a minor criteria? A, elevated erythrocyte sedimentation rate. B, polyarthralgia. C, elevated antistreptolysin, ASO titer. Or D, prolonged PR interval on an electrocardiogram or EKG.
See.
I heard B, C. It's C, ASO. That is not a minor criteria. The ESR and CRPR, let's go back to criteria. The increased CRP and ESR, prolonged PR interval, the arthralgia, but not an ASO. That's, remember, your underlying strep serology that you're using just to kind of prove that you have had some type of strep. So 2 major, 1 major, 2 minor. Those are your options. And then evidence of the recent group A strep. So that ASO might be evidence of the group A strep, but it is not part of the criteria. Questions about acute rheumatic fever? Let's briefly review impetigo. Impetigo, we said, is an infectious, a contagious infection of the skin. You covered this in feed, so I'm not gonna go into great detail, but there are three types, non-bullous, bullous, and ecthyma. The non-bullous is the most common, so that's the one you need to, be aware of or be more knowledgeable about. It can be caused by strep spirit species like Strep pyogenes, but it can also be caused by Staphylococcus aureus, and that's your most common. So you'll see what I bolded are your most common things you'll need to know for impetigo. The non-bullous is usually caused by both organisms, but the bullous type is usually only Staph aureus. Staph aureus is a gram-positive, coagulase positive, cocci in clusters. So it is similar to the strep in terms of the cocci, but it is clustered versus a chain. These patients are going to present with macules, vesicles, brulee, pustules, and honey-colored crust. Honey-colored crust, honey-colored crust, honey-colored crust. On different parts of the face and other exposed parts of the body. Your differential might be herpes, it could be an allergic contact dermatitis. Treatment is with soaps and scrubbing. You can use mupirocin topically, or you can orally treat with cephalexin. And what is cephalexin? Cephalosporin. What generation? First, second, third? Who? First. Yeah. Very good. All right, if it is an MRSA version of impetigo, methicillin-resistant Staph aureus, you could use doxycycline or Bactrim, the trimethoprim sulfamethoxazole. Do you all know what coagulase positive? Do you all remember what that means? No. So you'll see coagulase negative, coagulase positive. Coagulase positive means it produces an enzyme called coagulase, and I think a good way to kind of remember that, coagulase plays a role in how you coagulate. So when you coagulate, you're what? Clotting, yeah. You're clotting blood plasma or fibrogen. So coagulase, if you're coagulase negative, you don't have a lot of fibrin, so it would be thinner, right? And think of, if it's thin, it might spread easily, like a cellulitis or a sepsis. If it's coagulase positive, like in impetigo or Staph aureus, if it's coagulase positive, like in Staph aureus, then think of it being thicker, clotting, clusters, like your carbuncles or boilers, those types of things. You might see going to be probably, if you had an option, it's like, is it caused by strep? Or is it caused by Strep pyogenes or caused by Staphylococcus aureus? And they tell you that it's, like a cluster. You think coagulase positive, coagulase negative. Coagulase positive is the staph, that might cluster. It might be, a boil or something like that. And maybe you probably look for that. It might be more confusing, I don't know. But that's what coagulase is indicating when you see that described for bacteria. These are some great pictures of impetigo. You see that honey-colored crust around the mouth, that stuck-on appearance. In the top corner, you'll see those blisters. That's the bullous form, which is more common in which one? Staph aureus, yep. And then ecthyma, which is very rare. It's a deep type of impetigo. It starts out with this little pustule at the bottom, and then it turns into like a deep ulcer that can kind of crust over. That I've never seen. But those are the three types. Toxic shock syndrome, I added this, it wasn't in the lecture, just so you can compare the difference between the streptococcal toxic shock and the staphylococcus toxic shock, because this is the one you're gonna see the most. So that one I want you to be familiar with too. Originally, it was associated with absorbent tampon use, diaphragms, infections. You can see it in nasal packing, different things like that. So when you see toxic shock, your stem might include patient had heavy menses and was using 3 tampons in an hour or something like that. And then they presented with this abrupt onset of high fever, vomiting, watery diarrhea. those types of things. So that may be how they present this condition. Sore throat, muscle aches, headache, very common. But the characteristic part of toxic shock syndrome is this sunburn-like rash. So they have an erythematous macular rash that looks like a sunburn. It peels and it can involve the palms and the soles. So you'll see those hands down at the bottom kind of peeling red. That is classic for toxic shock syndrome caused by Staph aureus. Patients with hypertension, with kidney and heart failure have poor outcomes, and these patients need to be hospitalized. So they'll need some type of IV antibiotics or rehydration. MRSA, briefly go over. You want to remember this. This is a methicillin resistant Staph aureus. I'm not for sure if Professor Newman talked about it yet, but a lot of these people, some of these people are asymptomatic carriers. So a lot of people carry this. I've seen it in the nose quite a bit, but a lot of people carry it. So it's just on our skin. It's around. It can cause skin infections. Remember that coagulase positive, we talked about those clusters. So that's like the folliculitis, those boils, carbuncles. But MRSA can occur in the bloodstream. You can have MRSA-related pneumonia, and it can affect surgical sites. If you leave it untreated, you might have sepsis. Most cases can be treated effectively with incision and drainage. If there's an open, like there's like a boil or something like that. And you would treat that with Bactrim or the trimethoprim, sulfamethoxazole, clindamycin, or tetracycline. What's one adverse reaction you can think about with Bactrim or trimethoprim? That affects the skin. What's a scary one?
SJS.
SJS.
Yes, yes. Stevens-Johnson syndrome. And I actually I had a patient that had that after antibiotics, and she was almost blind. Her eyes still now are very red and they have like a covering almost over them. But she survived, so that's all we can be thankful for. If it's complicated, these patients are gonna need IV treatment, IV antibiotics, and that's usually with vancomycin. All right, so we're first gonna look at the picture and then we're gonna answer the question. So for pictures, I want you to just look, tell me what you think they are, or think about what you think they are, and then we're gonna say true or false. So for picture A, there is no additional treatment of this condition beyond treating the underlying pharyngitis. What is the picture showing?
Scarlet fever.
Scarlet fever, yep. You see that pallor around the mouth and you see that strawberry tongue. Is that true or false? There is no additional treatment beyond treating the underlying pharyngitis. It's true. If you want to treat the strep, you have to treat the strep, that's it. So whatever oral antibiotics you would use for strep, that's what you're going to use, and typically that's the type of penicillin. For picture B, what does that look like? Impetigo, yep. That honey-colored crust on the chin. This condition is most often caused by Streptococcus pyogenes. True or false?
False.
False, right. It is false. More commonly by what? Staph aureus. Good. C is a little bit harder to tell. And this is what you are going to be faced with in the clinic, because it might not look classic. But what do we think C is? It's hard to look at it because it's not very focused. If you look on your laptop, it's all down in the bottom.
Central clearing, what's that?
Yeah, there's like a clearing there and there's a raised border. So
Yeah.
C, erythema migraines is a major criteria in acute rheumatic fever. True or false?
True.
Who said false? Why?
Isn't it a minor criteria?
Huh?
Isn't it minor criteria?
Is it a minor criteria? No. What do we say about margins? Erythema marginatum. When you think of marginatum, it's a margin, it's a border, right? What did I ask you? Migraines, not marginatum. That's a trick question.
Oh.
Erythema marginatum is a major cautery, not erythema migraine. You gotta read.
Tricky.
All right, so our next topic is chlamydia, gonococcal infections, and syphilis, but we're gonna take a break. Why don't you come back at 9? And then we will kind of do a quick review.
What?
That's what I look at the picture.
On gonococcal infections and syphilis. We can play a little game. So, what
Game.
would you like to do?
Game.
Yeah. Something fun.
Let's go.
If you want to. I might say something.
Get ready.
Well, actually, it's like, get ready to go.
Roll me too.
Yes, oh, you did.
All right, let's get our minds ready. We're going back to G-Pan.
Dog sleep for the win.
We have 3 categories.
Oh, I love the.
Clinical clues, diagnosis discovery, therapeutic tactics. And each of these have like a bonus question. So, who wants to go first? Anybody?
I'll do it.
All right.
Ashley will.
your
Should we go
category.
right
Therapeutic tactics for 300.
All right, big gun.
Someone say she's pregnant.
Oh, yeah, clinically and subjectively. I mean, my phone. I would like to think a true date.
I don't know. There's been too much time to wait now. Now I'm studying. I'm reevaluating my decisions. I do that every day when I study. Good thing I did.
Most post-treatment infections of chlamydia result from treatment failure or reinfection.
Treatment failure.
Is it a true or false, or am I
This
just
is
trying to pick
what
which one?
is treatment failure or what is reinfection?
Oh, okay, what is treatment failure? Oh, I get the test of choice.
What is the treatment of choice for chlamydia?
Doxycycline.
Oh, you know what, guys, hold on. What else is the, yes, wait 1 second.
You're like, I donated.
Yeah, gram-negative bacteria. Another type of chlamydia species can cause pneumonia. That's chlamydia pneumoniae. That usually is an atypical type of pneumonia we see in school-age children and young adults. Typically mild, and a lot of patients recover with no treatment. So that's just something to be aware of. We talked about this. We're not going to go through it. Chlamydia, you feel free to go through these slides. These are straight from Professor G's lecture. Talked about that Fitzhugh-Curtis, co-infection with gonorrhea being common. Reiter syndrome is high frequency of that with chlamydia. Patients have arthritis, urethritis, and conjunctivitis. We talked about LGV and those inguinal buboes down at the bottom. Nucleic acid amplification testing is your gold standard and chlamydia. Treatment of choice, you already know, doxycycline. Alternative, azithromycin, you gotta add all of that. We're gonna treat all partners. Gonococcal, again, quick breeze through, second most common reported STI in the US. Caused by Neisseria gonorrhea, it is a gram-negative diplococcus. The age group, same as chlamydia, 15 to 24, the same age. Asymptomatic infection is common. Those are common symptoms in men and women. Other clinical findings, we talked about all of this before, so we're not gonna go into it. Disseminated disease, you're gonna see this again in MSK when Professor G teaches this in a couple of weeks. So you're gonna go back through that, but, that is a complication. Differential. Gonorrhea treatment of choice, same, NAT testing preferred. Treatment of choice, ceftriaxone. If chlamydia infection has not been excluded, you need to treat them with doxycycline. And again, treat all partners. Other management considerations, they need just to know about the treating, they need to avoid sexual intercourse, make sure they finish their medications. Abstain from sexual intercourse until all partners have been treated, no need to reinfect yourself, remember. Reinfection versus failure, treatment failure, reinfection is more common. Gonna test for HIV, gonorrhea, chlamydia, and syphilis. Follow up. Get through that, disseminated gonococcal infection, with arthritis and arthritis dermatitis, again, ceftriaxone. If you see gonococcal infection, remember ceftriaxone, plus azithromycin. And I don't remember if it was this one that, Dr. Professor G had said, you know, it's kind of a question if we add that azithromycin. But when we were taking our pan-rub now, so they still add azithromycin on there, so it might be on your hands, ceftriaxone and azithromycin. Even though things have changed, some of the testing material might be a little outdated. Conjunctivitis, I'm not gonna go through this is more common, you'll see that in peds, but it's a form of pink eye, most common in newborns. They are, susceptible to that because of the delivery, but adults can get it too. Syphilis is a lot, this is busy, busy. I know, but I just added everything I want you to know about syphilis in one slide. The top picture is the gentleman who were part of that Infectious experiment, which you may or may not be familiar with. But for syphilis, remember it is Treponema palladium, spirochetes, those are your keywords. You know how it's transmitted. Know those stages. What do you see in primary? A chancre. What do you see in the secondary? A rash. What do you see in latent? Maybe nothing. Tertiary. 3 common manifestations: cardiovascular, gluminous disease, and CNS involvement. Does anybody remember what the gluminous disease is? It's like that rubbery, nasty, yeah, right? Don't want that, yeah. Neurosyphilis, we talked about, it can occur at any stage. There are our bonus, Argyle Robertson pupils listed there, that tabes dorsalis. We talked about ataxia, burning, lightning pains, that's all part of the neurosyphilis. Testing, dark field microscopy is available. Screening with the RPR, VDRL, and you're gonna confirm with the FTA, ABS, or those additional antibody tests. Treatment, PNG, those are the doses. You just need to know PNG. Neurosyphilis, PNG, alternatives, if allergic, doxycycline, ceftriaxone. All right. Or who's eating right now? Might want to finish your thing. This is the nastiest part of preparing for this lecture.
Yeah.
We're gonna talk about foodborne illnesses, contaminated, do not eat, foodborne illnesses, food poisoning. We're gonna talk about a bunch of different things. Does anybody remember the controversy around Chipotle?
Yep.
Yes.
Yeah. That was a bit.
There were several outbreaks at Chipotle: E. coli, Salmonella, norovirus, Clostridium.
I was like 14.
So much so at Chipotle, this was like, I think maybe back in 2015.
It's been a
Yeah.
while.
So much so they had to pay $25 million to resolve criminal charges because of food safety management issues.
I know.
So much so.
No one told me about that.
Now, by raising hands, who has a forgiving heart, trusts Chipotle, or just doesn't care? I am guilty too. So, yeah, this section really makes you think a lot about what you're eating, who's preparing your food, how it's being stored. It gives you a lot of perspective. So the next 4 charts, I don't want you to necessarily memorize these, but you do want to look over my highlighted, what I think you might see a lot more commonly. These describe 16 different organisms. This is straight from current. 16 organisms, mostly bacterial, but some viruses are on this chart too, that are associated with contaminated food and water. Sometimes it's a matter of how the food is cooked. If it's undercooked, sometimes it's the way the food is stored. Other times, and what studies have shown is that 40% of those outbreaks at restaurants, it's from the employee. So, I mean, it may be, maybe they were sick, or it could be the great employee who decided to go take a number 2 and then washed their hands and came back and made your sub sandwich. So, you know, it's a variety of different things that can cause that. But on the chart, you'll see the organism, the incubation period, whether or not vomiting, diarrhea, or fever are associated, what types of foods, how you make the diagnosis, and how you treat, or clinical features. And you can see these are, there's a variety, some 10 hours, some days, reheated fried rice, that's a big one. I'm like, man, I love these. Undercooked poultry. Next one, you'll see E. coli, undercooked beef, unpasteurized milk, raw fruits, vegetables.
So you want us to just kind of more focus on those highlighted ones?
Yeah, and I'm gonna go over
Okay.
some of these. Yeah, the highlighted ones are the ones you're gonna see more commonly. And I'm gonna go over these in detail. For the ones that I want you to know. I'm gonna go back real quick. Because the second one, you see C. diff at the top. Now, typically we associate C. diff with what?
Diarrhea.
Hospitals, fires.
Antibiotic. It's like usually the patient's been on antibiotics, but, and I think I might have left that in your resource note, but, the hypervirulent strains can be associated with the consumption of pork and shellfish, which was new to me. I've only learned about antibiotics with that, so that was something new for me to learn as well. All right, that's just those 4 charts. So FoodNet, that is a statewide surveillance they use in various states that provide monitoring for 7 bacteria and 2 parasites that are known to cause foodborne illness, just to better understand the disease and look at trends. So, you know, there are some things you are gonna have to report to the health department, and those are listed there. Again, that's just a resource, not for you to memorize. First thing we're gonna talk about is botulism. This is a rare foodborne illness, but you have to know botulism. Botulism is going to be on your list. So botulism is caused by Clostridium botulinum, which is a ubiquitous, gram-positive, anaerobic, spore-forming bacillus found in the soil. So it's gram-positive, it stains purple. It is anaerobic. Does it need oxygen to grow?
No.
Nope, and it forms spores. It's a bacillus, so it looks like those little rods. This bacteria causes a neuroparalytic illness that classically begins with cranial nerve palsy. So these patients will have weakness of the muscles that control their eyes, their face, their mouth, their throat, and then it progresses to a symmetrical, so it's on both sides, descending weakness of the trunk, the extremities, and eventually a flaccid paralysis, so a floppy paralysis. This is different than Guillain-Barré, because Guillain-Barré starts from the bottom and comes up. So in a differential, if a patient is presenting with flaccid paralysis, floppy syndrome, like floppy paralysis, weakness, and they say it started with my throat, or it started with my arm, versus it started in my leg, that helps you differentiate between botulism and Guillain-Barré. A little bit of pathoform. The Clostridium botulinum does produce a neurotoxin that affects our nervous system, and it does so by binding to the cholinergic nerve terminals. And it basically breaks the protein we need to release acetylcholine. So acetylcholine is used to help us with muscle contraction. right? So if you don't have acetylcholine, then your muscles contract. If it's breaking up the bond of the proteins necessary to release the acetylcholine, then you don't have acetylcholine release. And that means your muscles aren't allowed to contract, which is why it's floppy. No, you have a weakness versus a spasmodic type of condition. So that you will learn probably with Professor Newman. But it also explains why Botox works. Because if you had, if you paralyze those muscles in the forehead, it causes, and they're not able to contract, it gives you a more relaxed look and it helps your wrinkles. So that's kind of how we think about Botox. So the botulinum toxin is one of the most toxic substances known. It is classified by the CDC as a high priority agent because of its potential to be used in bioterrorism. And that is because it only takes 1 to 3 nanograms inhaled to cause botulism. 1 to 3 nanograms. Anybody know what a nanogram is?
Real time.
A billionth of a gram. So we know how tiny that is. So they could easily, whoever hated, us or, in bioterrorism, we're gonna take down the United States. They can just spray it and we breathe it in and that's it. So it is a very high priority agent, that we're worried about because of that lethal dose. Botulism type. So naturally occurring botulism exists in 3 forms: foodborne, infant, and wound. Compared to the iatrogenic form that we use for cosmetic procedures. So there's 3 types: foodborne botulism, infant botulism, and wound botulism. The foodborne botulism is caused by ingestion of that toxin present in canned, smoked, or vacuum packed foods. So these are people who are doing home canned vegetables, smoked meats, vacuum packed fish, those types of things are where we find botulism. So the next time you go grocery shopping and you see that can of tuna that has a dent, put it back. Or if you see a can in your house that looks like it's about to explode because it's swollen, you probably don't want to open that. So those are things that are associated with foodborne, also low acidity food, so it's more vegetables. Think about the anaerobes. If this is anaerobic, it doesn't need oxygen, right? So if we're canning, making it where there's no oxygen, it can make that environment more likely. And that's if you're improperly canning. So most places where we're getting our Del Monte, or if you're buying canned goods, they have protocols. But when you're home canning, the USDA has put out like a guideline on how to can properly to avoid just this. This isn't gonna be on your pants, but when I was studying for your lecture, I did find something interesting. Homemade garlic oil. I don't know if there are any foodies in here, but you like cut up garlic, put it in a bottle and pour oil over it, and you're like, oh, I'm gonna use this to sauce dishes. That has been found to cause botulism. Yes, so it is not that you can't use it, but they say that it needs to be refrigerated and used within 7 days. So it's at room temp. So think about botulism. If it's ubiquitous, it's everywhere. It's in the soil, right? So if it's growing, you grab it. I got this garlic head out of the ground. I'm gonna clean it. I'm buying it. It's clean, clean, clean. Even at the grocery, it looks clean for the most part, but there's no way they can remove every particle of soil from that. So then you cut it, put it in your bottle, cover it with oil, leave it out at room temp. It's a chance, because we don't have oxygen now, because now it's covered in oil and it's in a bottle where it's no air coming out. That anaerobe has a chance to form those spores. So that's kind of how that works. But yeah, so definitely if you are making that, you need to refrigerate it and use it within 7 days. So I thought that was interesting. All right, what are the signs and symptoms of botulism? Typically, these patients have visual disturbances about 12 to 36 hours after ingesting. So in your stem, in your pants, the patient ate a can of home canned peaches, something like that. And then 12 hours later, or the next day, they had double vision. So the patients are gonna come in with diplopia, loss of accommodation, ptosis or drooping of the eyes. They can have ocular palsy. Remember those cranial palsies that then progress to the symmetric descending weakness, They'll have ocular palsy, they'll have they'll have fixed dilated pupils, and they could have blurred vision. So those are the visual disturbances. Other symptoms that are common, dry mouth, dysphagia, dysphonia, muscle weakness, progressing to respiratory failure. Why would they maybe have dysphagia? If you think about the muscles not being able to contract, if those muscles can't contract in your throat, are you gonna be able to swallow? It's gonna be hard. It's gonna be hard to swallow. And that is also the vocal cords, so they may sound spasmodic and they're talking, things like that. So, those are the signs and symptoms. In foodborne, you might also have nausea, vomiting, diarrhea, abdominal pain. And in the infant, look at that cute little baby, he's got floppy baby syndrome. That's what they call it in infants. They may present with constipation. They may have poor feeding, a weak cry because they can't get their cries out. Remember that respiratory failure that can happen. Those respiratory muscles are weak too. Latin facial expressions, physical exam. These patients usually don't have a fever. They have no loss of sensory function. They think clearly. They are fully aware of what's going on, which I think is scary, but, they have full control of that. You might see on your exam, the visual, they may have those visual disturbances. They're telling you those symptoms. You might see a dry mouth. They could possibly have some postural hypotension or orthostatic hypotension. But in terms of touch, vibration, those sensory type things, everything there. Differential, pretty extensive. Remember, we talked about that Guillain-Barré, poliomyelitis. Polio is not very common. Myasthenia gravis. Those are some common ones. For the upset, for the foodborne, possibly intestinal obstruction or other types of food poisoning. Let me go back. I just realized, guys, bear with me, first day. Those types, I didn't go over my other one. So we talked about the foodborne, but infant botulism, I need to definitely talk to you about because this is another pants question. They're only gonna ask you one botulism question. It's gonna be about home canned foods, or it's gonna be about honey in a 4-month-old, a 6-month-old, a 11-month-old. This is why we don't give honey to babies under 1 year old. Because studies have found ingestion of honey associated with botulism, even though that is not the sole cause of botulism in children. So remember that honey, home canned vegetables, always tie those with botulism in a patient with visual disturbances, some type of weakness, some type of flaccid paralysis. Womb botulism, not probably gonna be on your test, but you should know about it. It's the third existing form naturally. And we see that in patients who use drugs, drug use, particularly black tar heroin, that I don't expect you to know. But definitely the infant and the foodborne to be very familiar with. I got on my tangent about the garlic and lost my place. Okay, so, the differential diagnosis, initial diagnosis is based on symptoms. These patients come in, you're gonna treat them. You are not gonna wait for confirmation. Do not wait. These patients can die. If their muscles in their respiratory muscles aren't working, they cannot breathe, okay? So we're not waiting. They need to be treated immediately. You can obtain a culture for the presence of the toxin. Can you have your wife go get those canned peaches for me so we can test them? Or if it's in a wound or the stool or the food that they ate, you can do that. There's some other routine tests you might order. Those are usually normal. If a patient's having those visual disturbances, palsies, and weakness, you want to rule out a cerebral vascular accident or stroke. So you might want to get a CT and an MRI. Treatment. If you have no allergy to horse serum, it's going to be equine serum heptavalent botulism antitoxin. Again, these are not going to be handy dandy in your primary care office. These patients are going to be at the hospital. You're probably going to have to call the state. CDC might have to be involved, but you're going to treat that with antitoxin. And it needs to be given within about 24 hours. Again, do not delay treatment. Do not delay treatment in botulism. If they have these symptoms, treat them. Respiratory paralysis may lead to death. These patients might have to get on a mechanical vent. All right, botulism is a reportable illness. I left you a resource at the bottom. It's from COMAR, which is basically our reporting system in the state of Maryland. So if you were to see a patient with botulism, which is unlikely in your lifetime, you would need to contact the state and the CDC. There are ways, typically for providers, I would say most of us aren't having to report. You may have to fill out forms because your lab, whoever you ordered it from, they're reporting that. They're reporting that they found botulism. They're reporting that they found these things. But there are several things like AIDS, chlamydia, gonorrhea are also reportable, diphtheria. There are several different types of illnesses that have to be reported to the state, and you'll see that in your resource. We're not doing that for testing purposes. You do not have to know the piece. Botulism, it's just, I mean, you might see with the foodborne type, like home canned vegetables and the honey, if you do it, but typically, like when you had a new baby, your pediatrician is gonna tell you, do not give the baby, you're talking about what you're feeding, this and that. They're gonna tell you, they're gonna drill that in your head. No honey before one, those types of things. You might with home canned vegetables, things like that, but again, it's just not very common. We don't see a lot of botulism. Yes, actually.
Is there any type of like contact protocol or like isolation these patients have to go?
Not that I'm aware of.
And then would you, I guess, treat any, like, if it's like canned food or something that like multiple people have eaten out of, would you treat those
They
individuals
may
as
have
well?
to be treated, yeah, especially if they show symptoms. Yeah, and it's gonna be quick. So
Yeah.
it's like a family, usually within the first 1 to 3 days,
They'll all present. with
they're
it.
gonna present with something if they all have that. All right. This is the resource. And as much as I hate to break it to you, this chart is not the description of chocolate you might have received from your boo yesterday and you're looking forward to it. We have not candy bars. This is diarrhea. We're gonna talk about acute diarrheal diseases.
Now I'm so sick of chocolate.
As we mentioned before, top 10 global causes of death, diarrhea was on that list. So you definitely need to know these. Why do we think diarrhea is an issue?
Electrolyte
Fluid
loss.
Yep, but where do you think, like, well, I guess most cases are from contaminated food and water sources, so that's why we see it on a global type of thing, and that's because a lot of people don't have clean and safe drinking water. I think it was 2 billion people do not have access to clean drinking water, and 3.6 billion, or 46% of the world's population, do not have access to sanitation services. Now, some of that is prioritized, but some people are forced because of their living conditions, because they live in a poor country that does not have access to these things. They have to go defecate in a field, defecate in a creek gutter, defecate in a body of water. And that same wastewater is sometimes being used to irrigate their food, even if it's partially treated or untreated. So you can see how that might create a problem around the world. Fortunately for us, we do have a lot of, we have adequate sanitation services. We have toilets, but a lot of people don't. So what is diarrhea? Diarrhea is defined as stool with increased water content, volume, and frequency that lasts less than 14 days. This is acute diarrhea. So increased water content, increased volume, increased frequency that lasts less than 14 days or 2 weeks. This is in contrast to persistent diarrhea that might last for a couple of weeks or some type of chronic diarrhea. Most cases of diarrhea are due to infections, food poisoning, and medications, but you can also have food intolerance, and there are diseases that affect the bowels that can cause diarrhea. We are talking about infectious disease. The most common etiology of acute diarrhea is viral gastroenteritis, which is usually self-limited, and probably most people in here have had gastroenteritis at some point in their life. These are typically norovirus, rotavirus, adenovirus. Norovirus was one for the Chipotle controversy. So it's very common, but usually does not require treatment. Some of the other major causes of infectious diarrhea are bacteria and protozoa. So you'll see Shigella, Shiga toxin producing E. coli, Vibrio, C. diff, Giardia, Entamoeba causes amoebic dysentery, so a lot of different causes of infectious diarrhea. And it's not easy to determine what caused what. Was it a bacteria? Was it a virus? Was it a parasite? Because they all tend to present similar. So it might be hard to distinguish, but you don't necessarily need to know what it is to manage it. A lot of these are just supportive care. The first one we're gonna talk about is cholera. Cholera, is caused by Vibrio cholerae, which is a gram-negative bacillus, meaning it's a rod. It used to be pretty common back in the 1800s, but that was before we had modern water and sewage systems. Now it's pretty rare in the US. This map shows endemic areas, where there's still an issue with cholera, primarily in Africa, Southeast Asia. Haiti is there as well. So if you have a patient that, comes from Haiti and you might see that. Or a patient that's traveled internationally to one of these areas, you might see it. Gram-negative bacteria usually do not form spores. So I just want to remember that, I want you to remember that, 'cause we're going to talk about some other spores coming down the line. But this is acquired by ingestion of contaminated food or water. Like we said, it's rare in the US. Nearly all cases reported in the US are acquired during international travel. Contaminated seafood brought into the US can also cause cholera infections. Again, you see why I'm like, I don't want to eat anything while I was preparing for this lecture. It's just like, you can't, nothing's safe. Diagnosis, these patients have traveled to an endemic area or they've had contact with an infected person. This is a voluminous diarrhea, up to 15 liters a day. That's 4 gallons of diarrhea a day, 4 milk jugs of diarrhea per day. That is a lot. Okay,
I just say, wasn't cholera the one that they found in like the water
pump in
and the water pump in like England? You think about all of those people, like.
yeah, how much poop they.
How much poop?
Yeah, again, why I said you might.
Is it?
Not a fun lesson.
And this study,
But yeah, it's a lot of diarrhea.
Cannon.
So, the characteristic finding for cholera is a rice water stool. Rice water stool, rice water stool, rice water stool. Rice water stool.
Nice, Nick.
This is pants, high yield characteristic,
Oh my.
rice water stool. You can see in that pill, it looks like they've washed rice. So it's a gray, cloudy, mucus-like stool, usually no blood, no odor, just pure liquid.
Fire hydrant.
These patients, have rapid development of dehydration, and this volume depletion can lead to hypothermic shock and metabolic acidosis.
Oh, you meant like a couple of days ago.
The differential, regular viral gastroenteritis, like noroviruses type thing, intestinal diarrhea, this is not very specific, food poisoning with Staph aureus. The culture of stool remains the gold standard. The stool culture remains the gold standard. There are other tests that you can see there, but I've highlighted and bolded what you need to know, stool culture for cholera. You need to replace those fluids. If you are pooping 4 gallons of poop, you need your fluids back. So we need to rehydrate these patients. If it's severe, they are going to need IV. I think I may have left a recipe for a simple oral replacement, in the resource. I'm not for sure. Which is like half a teaspoon of table salt and 6 level teaspoons of sugar and a liter of water. That is sufficient to replace fluid. But if you're not for sure, send them to the hospital for IV hydration. More severe cases, you might need antibiotics to shorten the duration, and those are some listed, but the big one here is replacing those fluids. If you have a patient traveling to one of these areas, they need to be vaccinated. This is a resource, just different treatment options. If your patient does require antibiotics, again, fluid replacement. We'll do vibriosis and then we'll take another break. Vibriosis, Vibrio is a species. There are about 20 of them that can cause illness. This illness is called vibriosis. The 3 here, Vibrio parahemolyticus, Vibrio vulnificus, and Vibrio Allergenolyticus are, the most common ones we see here in the United States. Cholera is a Vibrio, but it is not considered a vibriosis. It is in its own category, okay? Vibrio vulnificus, is an infection, that's rare, but is a leading cause of death based on seafood consumption. And typically, you find this in oysters. Uncooked, undercooked, contaminated oysters on the, half shell type thing. This is a ubiquitous, it's found everywhere, gram-negative bacteria found in warm, salty water, so that's the connection with the seafood. This is typically found in warm ocean water or brackish water. Is anybody familiar with brackish water? Does anybody know what brackish water is? Yeah, for those that don't know, it's a mix of salt water and fresh water. And where would we find that around here?
Chesapeake Bay.
The Bay. The Bay is the biggest area of brackish water in the United States, the biggest estuary. The Vibrio does not cause food to smell funny, taste funny, look different, so you wouldn't even know that you have been, that the food's been contaminated with it. It causes a watery diarrhea, nausea and vomiting, abdominal cramping, fever, but can also cause these blistering skin lesions, which we're gonna see on the next slide. So Vibrio vulnificus can cause cellulitis, wound infections, and bacteremia, infection in the blood. Remember earlier, we talked about necrotizing fasciitis. This was the other, one of the other bacteria that causes necrotizing fasciitis, Vibrio, staph, and strep, yes. These wounds, are bullous necrotizing wound infections after exposing an open wound to this warm coastal water. So you may have an open wound, but you could easily have just an unhealed tattoo or a new piercing and go hop in the Chesapeake Bay. Next thing you know, your leg is broken. So it does happen.
I'm surprised I've never.
It doesn't have to be a big cut. I mean, it can be something small like a tattoo that's just not healed yet or a piercing. So be careful getting in that type of water, with those types of, things going on. Yes.
I'm just gonna share a story.
Yes.
My brother and his friend, they're like both big fishermen and, he got bit by a crab. And, you know, I mean, they didn't think to like clean their hands immediately, now they do, but yeah, he got Vibrio on his hand and like luckily, like, we've been familiar with it, like living like down, like in the bay and some of the river area, so it's definitely like very common. Him and his best friend ended up being like really bad. He almost lost his foot, but his was like just his finger because we were like, yeah, you need to like go and get that. Originally, they were like, oh, you just pulled a tendon, and then it started getting worse. And it was like, yeah.
Something, yeah.
Yeah.
It's real,
Yep.
and it's here, this area, you might see it very commonly, so, thanks for sharing, Elizabeth. Let's see. On the second one, on the second bullet, it also says hurricane flood events, so, like she was saying, they were fishing. You could be fishing, you could be swimming, just doing normal water activities, but what if it's a hurricane or a flood event? That water can be contaminated too, so you may not even actually be in the water, but be affected by maybe your basement, there was a hurricane or a flood event and you got into that water and you had an open wound or something, so. That is also a secondary possible exposure. High-risk patients are those with liver disease and cancer, diabetes, immunosuppression, immunosuppressive therapies. Patients with liver disease or that are immunosuppressed are often warned not to avoid raw oysters. Avoid raw oysters in those patients. Like she said, he almost lost his foot. This can lead to amputation or sepsis. You want to treat fluids that are lost to the diarrhea. Antibiotic-wise, doxycycline plus ceftriaxone would be used in this case. When you come back, we'll do salmonella. It is 9:56, come back at 10:06. Which is pretty scary. Sharing that with us. That's scary stuff. All right, salmonella. This is another leading cause of foodborne disease in the United States. It causes salmonellosis. The CDC estimates 1.35 million illnesses due to salmonella, and 420 deaths occur due to the non-typhoidal type in the United States. These numbers, I don't expect you to memorize. This is just for your information. On average, there are 900 to 1,000 confirmed salmonella infections reported in Maryland. And I put these two pictures because those were two of the most recent outbreaks I found, which is cantaloupe. It was a whole type of cantaloupe. Those are no longer for sale. And that is a certain brand of a charcuterie sampler, like a meat sampler that was sold at Costco and Sam's.
Yeah.
Those have since been taken.
I remember when I saw that.
I got that.
No, I just remember seeing a report about that.
No, they do sell cantaloupes. They don't sell that, the one that was causing the salmonella.
So they don't have
Has
something
since
about
been-
it.
It's no longer available. for no one.
I like honeydew.
I don't like honeydew, but I like
Yeah.
cantaloupe.
I'm a honeydew girl.
You like
Lot of
Over
fruit.
cantaloupe.
Um,
I like
cantaloupe.
cantaloupe.
Non-typhoidal salmonella,
Never really-
is a major cause of diarrhea worldwide. Again, this is a gram-negative bacillus, it's a rod. Salmonellosis is the illness caused by Salmonella enteritis. Primarily, this results in a mild to severe diarrheal illness known as acute gastroenteritis. This can range from diarrhea, abdominal cramps, and fever, but can be invasive. Oh, that was I think sprouts, yeah, alfalfa sprouts. Those have been recalled due to salmonella in the past as well. Salmonella is associated with the ingestion of contaminated poultry, eggs, meat, and milk products, fresh produce. Again, you can't eat anything. And then there are pet foods. Pet foods can be contaminated with salmonella, as well as contact with pets. Reptiles tend to harbor that bacteria in their intestines, and so they can spread it to every surface that they touch. So if you have an iguana or a bearded dragon or at home, that has salmonella, it can, infect a person. So that's that animal to person type of, communicable disease we talked about in the very first definition slide. Clinical manifestations, symptoms of salmonella gastroenteritis typically occur within 8 to 48 hours following the exposure. So it could be that same day, or it could be 2 days later. Longer incubation periods have been reported. I saw up to 72 hours to 6 days. So, it doesn't have to be as fast as what is listed, but, 8 to 48 hours is typical. The features of salmonella gastroenteritis are not distinguishable from other types of gastroenteritis. They're all going to present pretty similar. So it's going to be hard to differentiate which is which. The enteric infection with non-typhoidal salmonella may clinically even be asymptomatic. Cardinal features, diarrhea that may be bloody. Salmonella, diarrhea may be bloody. They also have just those general non-specific nausea, vomiting, fever. They will have abdominal cramping, usually only lasts a couple of days. Higher ingested doses correlate with the severity of the diarrhea, duration of illness, and if you're gonna lose weight due to that. So you eat something contaminated, you decided you were gonna have a charcuterie board party so you could post it on your IG. Everybody got sick that next day or within the next couple of days, bloody diarrhea, nausea, vomiting, cramping, last 3 days and resolves, possibly salmonella gastroenteritis. Again, it may or may not be bloody. That's just gonna be important when you're differentiating between these diarrheas. Diagnosis and evaluation, generally suspected as part of a differential whenever somebody presents with acute diarrhea. I think salmonella, salmonellosis, gastroenteritis, particularly when accompanied by the abdominal cramping and fever. These are community outbreaks. You had a picnic, you had the food, and everybody's sick. Diagnosis, definitive diagnosis requires isolation of the pathogen in a stool culture, but this is not always warranted. You don't necessarily need to go through the motions of confirming that diagnosis if that's what you think it is. You might need to do a stool culture in these populations. If it's severe illness, if it's an immunocompromising condition, if there are comorbidities that increase the risk for complications, blood cultures should be obtained if the patient remains ill or are febrile. But you can see that differential viral gastroenteritis, food poisoning, shigellosis, which we're going to talk about, amoebic dysentery, ulcerative colitis. Those are very common in the differential for gastroenteritis. Usually self-limited, don't necessarily need to do any major treatment with it, just kind of let it pass through your system. The fever generally resolves within 2 or 3 days. Diarrhea usually resolves within 4 to 10 days. You may need to replace fluids, depending on the severity of that diarrhea. And again, we said it depends on how much of the bacteria you actually ingested, how severe it is. Fluoroquinolones can be used for those with severe disease or risk factors for invasive disease. What is an example of a fluoroquinolone? And what's another one? Two questions. All right, shigellosis. As we continue to look at sources of acute diarrhea, shigellosis is another common one that you might see. Shigella dysentery is a common disease, often self-limited, so not going to need any treatment, and mild, but it can occasionally be serious. Again, this is a food or waterborne illness, but unlike some of the others, can be communicable from person to person through sexual contact. And in bold, fecal oral transmission. Fecal oral transmission. They have found that men who have sex with men are at higher risk because of sexual contact. But again, like we said, your friendly sub maker who decided to go take a number 2 and didn't wash their hands when they came back to prepare your sub, this is possibly the source of that bacteria. In the United States, Shigella soni is the leading cause. There is another form, Shigella dysenteriae, which is very rare, but causes the most serious form of the illness. You only need 10 to 200 organisms to be infected with Shigella, so it doesn't take a lot. There are several multi-drug resistant strains as well, so if a patient did require treatment, it might be a little bit harder to treat due to resistance. Some of the person-to-person risk groups, children is the main one. This is most common in children under 5 years old. You might have got some of this with Professor Rogers, if not, you will when she does infectious disease. But it can be spread from person to person, and sometimes, even after your diarrhea is resolved, you can keep spreading it for weeks. So that's the dangerous part of that, and how it only takes, so little to have it. So you're gonna see these outbreaks in childcare, schools, gatherings like class, homelessness, cruise ships, those kind of things. So other people at risk would be travelers or persons with weakened immune systems, and that is Shigella, which looks like a little caterpillar on the side. Signs and symptoms. This is going to be an abrupt diarrhea, often bloody. Shigella, bloody. Salmonella, maybe bloody. Salmonella may be bloody. Shigella, think blood. Bloody poop, bloody diarrhea. It might contain mucus. They have lower abdominal cramps, and they have tenesmus. Do you all know what tenesmus is yet?
No.
Yeah,
Yes.
it's like you feel that you have to like defecate, but not necessarily anything to defecate.
Right. It is a painful desire to have a bowel movement, and there's nothing in your bowels to be released. There's nothing in there to come out, but it feels like you have to go. They also have some non-specific symptoms, fever, chills, maybe loss of appetite, fatigue, malaise, headache, tender abdomen. Lab findings, stool may show leukocytes and red cells. Stool culture is positive for Shigella. This is a picture of a colonoscopy. Sometimes you'll see an inflamed, engorged mucosa with ulcerated areas. This one has multiple ulcerations. It's swollen, it's red. That may be something you see. That's just a resource. But it resembles inflammatory bowel disease. So, but you might be thinking about your differential diagnosis because of that. ulcerations in the colon, things like that, this is for you to start thinking about what other things might look like that if you had to do a colonoscopy on these patients for whatever reason. Differential salmonella, enterocolitis, E. coli, enterotoxigenic E. coli, Campylobacter and Yersinia. Amoebic dysentery may be similar clinically and is diagnosed by finding amoebas in a fresh stool specimen. Ulcerative colitis is another cause of bloody diarrhea, so that should be something you're thinking about in a patient that presents with bloody diarrhea. For treatment, we are treating the dehydration and the hypotension, which could be life-saving in severe cases. Impaired antimicrobial treatment with ciprofloxacin, or Levaquin. And those again are what? Fluoroquinolones, right? Other treatments might be ceftriaxone, azithromycin, Bactrim, if susceptible. Ignore that azithromycin highlight. I don't know why I bolded that. Just remember ciprofloxacin. Ciprofloxacin, those are other treatments, but ciprofloxacin or fluoroquinolone for this. It is significant. There is significant resistance to amoxicillin, so that is probably not a good choice for Shigella. Questions about Shigella? All right, moving on to C. diff. Clostridium difficile. Why they changed the name, I have no idea. It used to be Clostridium difficile when I was in PA school, and they changed it to Clostridium, which is super hard to pronounce compared to Clostridium, but that is what we are going to discuss next. And remember what we said in the beginning, even though we typically associate this with antibiotics, it can be associated with more ailments. Port was one of the things that the hypervirulent strains can be found with. But this is a leading cause of nosocomial antibiotic-associated diarrhea. It's a gram-positive, spore-forming, toxic-producing anaerobic bacterium. Does it need oxygen? No, it does not. This is readily transmitted patient to patient by hospital personnel. So here's where you come in. Now, these patients might be in some type of isolation, but definitely wash your hands, wash your hands, wash your hands. Practice good hygiene with your patients. In an outpatient setting, this patient might come in to you, they've been recently hospitalized, or they've been on a course of antibiotics. Clostridium difficile can occur without prior antibiotic use. You do not have to have antibiotics to get C. diff. But when we talk about it, it's going to be more commonly associated with antibiotics. The antibiotics tend to change the colon, the bacteria that allows, it changes the normal colon bacteria, which allows C. diff to grow and produce those toxins. Toxic mediated C. diff infections range from mild diarrhea to pseudomembranous colitis and potential death. Pseudomembranous colitis is a severe inflammation of the inner lining of the large intestine that is a complication. So some high-risk antibiotics are clindamycin, but other high risk would be some fluoroquinolones. Second and third generation cephalosporins are all high risk antibiotics for C. diff. Clindamycin, fluoroquinolones, and second and third generation cephalosporins. You need to know that. Some of our major risk groups would be patients that are older, have a weakened immune system, or somebody, like we said, maybe they had a recent hospitalization, or they live in a long-term care facility. These are patients that we're worried about. Healthy individuals who have not been on antibiotics can develop C. diff. We have seen this in patients with inflammatory disease like Crohn's or ulcerative colitis. And some studies suggest, I saw this on a high yield question, PPIs, proton pump inhibitors. Proton pump inhibitors may increase the risk of C. diff. So So keep that in mind. Will that be on your pants? I don't know if that's too new. Definitely clindamycin for quinolone and those, cephalosporins that we discussed. You can ingest the spores, they're everywhere. Remember, it is a ubiquitous type of, they're all over the environment, so, patients can excrete the spores in the hospital, and that can cause an issue that has been well documented, transmission in the hospital. All right, symptoms. So symptoms of C. diff may begin a few days to a few weeks after antibiotics, so this may not be immediate. They may present with diarrhea, which is often watery and rarely bloody. Rarely bloody. Salmonella, bloody or not bloody? Maybe. Shigella, bloody or not bloody?
Bloody.
Bloody. C. diff, bloody or not bloody?
Not bloody.
Usually not, rarely bloody. So, remember those when you're trying to differentiate between these different diarrhea causes. C. diff, sometimes it's explosive. When I first, we actually have to prescribe quite a bit of, fluoroquinolones and clindamycin in ENT. And, when I first started, my doctors would always say, you know, if you're not gonna be able to make it to the toilet, like that explosive type diarrhea, you need to call us and let us know. Don't keep taking the antibiotic, call us immediately. So, sometimes C. diff has a strong odor. The patients might say it smells weird. Some people describe it as a sweet odor, not that that means it's pleasant, but it's just like a strong sweet odor, for some patients, that may have C. diff. Other symptoms, crampy abdominal pain, fever, loss of appetite, nausea, vomiting, those basic ones. You're gonna see those in all these: abdominal pain, fever, loss of appetite, anorexia, nausea, vomiting. But another one with C. diff, if it's severe, sometimes their stomach actually hurts. It's a tenderness to touch, and their stomach might be distended. So that's another way to differentiate C. diff. Diagnosis for C. diff: 3 or more unformed stools in a 24-hour period for 2 or more days with no other recognized cause. 3 or more unformed stools per 24 hours for 2 or more days with no other recognized cause. Your stem is gonna say, patient had 6 episodes of diarrhea in one day and presents today with abdominal pain, what is your, most likely diagnosis, or whatever it's gonna ask for the test. So, that's what you wanna know. 3 or more unformed stools in a 24-hour period. Standards treatments for C. diff. Now, I watched Dr. Noel's lecture via Zoom with Professor Newman. What medication typically given IV can you give orally for C. diff?
Vancomycin.
3, y'all got 3. You got at least 3, yes. Vancomycin, metronidazole, how can I say flagyl today? What, say it?
Metronidazole.
Metronidazole. I just cannot. Look, guys, I hardly slept last night. I felt like today was like 9th grade, and I was like, oh, today, and I could not sleep. So I'm like running on fumes. So my brain is like, so please forgive me. But yeah, standard treatment: vancomycin, metronidazole, and fidaxomicin. I don't know how to say that one. Those are the common ones. You need to know rank. You need to know flagyl. This is essentially a resource. This is how you would prescribe it. I don't know what he's testing you on. If you need to know that, maybe this is extra help for you. But this is essentially a resource, but I do want you to look at the very bottom where it says multiple recurrences. Fecal microbiota transplant. Does anybody know what that is? Food transplant, yes, and that to me is just interesting, like, oh. So you're under sedation, they collect feces from some healthy person, not having any of these issues, and they transfer it via colonoscopy or enema. I think they even said capsule form. nasty. Put it in me somewhere, other way, I'm not swallowing food. Healthy bacteria basically begin to grow and prevent that C. diff from, recurring, so I think that's pretty interesting. These donors have to be rigorously, screened before they can donate their poop. I don't know how much that costs, maybe that's a good way for you to have a little side school.
Don't do that.
Donate-
Don't do
Donate-
Throw it the fuck away.
But,
Like I get storing cord blood.
all right.
Like,
Yeah, good on time. We are gonna do
Thank
some
you.
other communicable diseases, we're leaving diarrhea
cannibalism.
and going to a couple of other conditions, diphtheria being the first. Now, as I told you before, I have 13+ years of experience in ENT. I have never seen diphtheria. Ever, ever, ever. Diphtheria was a leading cause of childhood illness in the 1920s, but now it's extremely rare in the United States. And that is likely due to vaccination. What vaccinations include diphtheria?
Yeah.
Right. Infections caused by Corynebacterium diphtheria. It primarily affects mucous membranes of the throat and nose, but can also involve the skin. Respiratory droplets or direct contact are your routes of transmission. It is vaccine preventable. The higher risk situations would be in overcrowding situations, patients who didn't complete their vaccines, and then of course our poor immunosuppressed patients who are just at risk for everything. This is a gram-positive bacillus spore-forming bacteria. It is the toxin from diphtheria that makes people sick. So essentials of diagnosis, this is what you're gonna see. There's a tenacious gray pseudomembrane in the throat or on the skin. Symptoms are generally non-specific and can look like an upper respiratory infection, but this cutaneous type you see at the bottom, you might have a non-healing ulcer, and then it's covered with this gray membrane. And the back of the throat is it's just, you can't really, it looks unlike anything else, but it does look similar to other things. What, if you saw that in a patient, what would you think?
Maybe.
What are some possible things you might think that might be up at the top? Strep, possibly. What else? Mono. Mono looks nasty like that. Mono is white, chunky exudate all over the back of the throat. What else? Thrush, yes. Oral candidiasis is another one, that could easily think that, could be. These patients might also have sore throat, nasal discharge, hoarseness, fever, again, viral type symptoms. The exotoxin is responsible for myocarditis and neuropathy. These are the most common and most serious complications of the disease, the most serious complications that we see. Myocarditis occurs in about 60% of patients, especially if they've never been immunized. This can cause heart block, arrhythmias, and heart failure. If patients have severe disease, they might develop neuropathy. And this would include the cranial nerves first, causing some double vision or diplopia, slurred speech, and possibly difficulty in swallowing. For differential is here. We talked about strep, infectious mono, viral cholangitis, oral candidiasis. Two other ones that we did not mention were Vincent's angina, which is the ulcerative gingivitis. Sometimes that's called trench mouth. Never seen that, but that is the possible differential. Arcanobacterium, that is a rare cause of sore throat, and it produces a scarlet-like fever. Scarlet-like rash, like a scarlet fever-like rash. It is not scarlet fever. It produces a rash like that. So what was the rash of scarlet fever?
Sandpaper.
Sandpaper. Does it blanch?
Yes.
Yes. Can it be red?
Yes.
Yes. Treatment. Diphtheria antitoxin, gotta get that from the CDC. They also will treat with a toxoid booster if you are not up to date And you can see down in the bottom, just a little reference for the Tdap, DTaP, TB, Tdap for adults, every 10 years, the age groups. Of course, I'm not testing you on anything pediatric in this class. Yes, Sharon. You might, the state might have something, at a facility, but if not, then you would have to get it from the CDC. They may or may not, those are rare, yeah, so you're gonna have to, I mean, they would get it to you ASAP, overnight, they're gonna fly it out, whatever they have to do to get it to you. And there may be like some facilities close by that may have it. Here, we have Johns Hopkins, we have so many teaching hospitals, we probably have a lot of access to things, but yeah, it's not gonna be readily available, for sure. Therapeutic procedures, they need to come see me, they need to come to ENT, they're gonna need removal of that membrane by direct laryngoscopy or bronchoscopy or general surgeon. They will need this to alleviate that airway obstruction, I mean, just by looking at that, I don't know how they're getting any air down there, I don't know how they're even swallowing, because it is completely, taken over the back of the throat. Other considerations, this is one of those reportable diseases, so you do have to report this to the state, and you need to admit all suspected or proven cases. These patients need a consult ASAP. All right, tetanus, which you probably are familiar with. Tetanus, also known as lockjaw, is caused by Clostridium tetani. This is a ubiquitous, everywhere, gram-positive, spore-forming, obligate anaerobe. Tetanus is caused by the tetanospasmin, and it is found in soil. It can germinate when introduced into a wound. Neonatal tetanus enters through the umbilicus, so when they cut the umbilical cord, they may be introduced to this. Again, we're not doing beats here. Tetanospasmin interferes with neurotransmission at the spinal synapses of inhibitory neurons. Tetanospasmin interferes with neurotransmission at spinal synapses of inhibitory neurons. To my ENT brain, that was like, so basically, in basic terms, the toxin is going to be introduced to your body from the soil, from dust, or from some object that's contaminated. Can be from a crush injury. Most commonly on the pants, it might say patient stepped on a nail, or they had some type of puncture wound, something like that. But it's gonna travel to your nerve endings, bind to those nerve endings, and then disrupt the release of the neurotransmitters that are responsible for regulating our muscle contractions. So if you're not able to control those muscle contractions, you're gonna end up with muscles that are on 100. They're going crazy, like your muscle contractions are just uncontrolled, they're excessive. Your reflexes are exaggerated. These patients are stiff, they have spasms. Professor Newman will probably go into this a little bit more, and she can correct me from my basic terms. I am not a pathologist teacher, but that's how I understand it. Incubation period is 5 days to 15 weeks. So it can take a while. 5 days to 15 weeks, but the average is about 8 to 12 days. And this is what we want to remember, that contaminated wound, it's caused by Clostridium tetani, based on the neurotoxin that travels to those nerve endings, disrupts the release of the neurotransmitters that regulate the muscle contractions, and you are left with spasms, excessive muscle contractions for this poor guy, severe hyperextension and spasticity that is caused by the botulism. So you can see that everything is contracted for him at this point. His neck, his arms, his feet, his toes, everything. No thank you. Tetanus, most cases occur in unvaccinated individuals or people who didn't receive their booster. People at risk are going to be your older patients, migrant workers, newborns, injection drug users. Any wound can be colonized and infected by tetanus. See Clostridium tetani. So it could even be a bite, dog bites, cat bites, anything, human bites. Clostridium does not have to be a puncture wound, just from like a nail or some object. Signs and symptoms. The initial symptom is pain and tingling at the site of inoculation, followed by spasticity of the muscles nearby. So he said that this is called lockjaw, and that's because of the trismus and stiffness of the jaw, that the spasms in the face. This could cause some drooling, neck stiffness, dysphagia, irritability. The picture shows something called rhesus sardonicus, which is like this permanent, it's not permanent, but they have this grin like the bottom picture. It's just like kind of like a stuff. But that's what they look like sometimes. It's an abnormal sustained spasm in the face, looks uncomfortable. But those are the things you might see. Also, hyperreflexia, which we talked about in that first picture with the guy that was completely, out. Heard the rigidity and spasm of the muscles of the abdomen, neck, and back, painful tonic convulsions. They say that the muscle contractions can be so excessive in tetanus that you can break your bones. It can be bad. It's just that much. Muscle tears, everything. It can be very bad. Spasms of the glottis and respiratory muscles may cause acute asphyxia, so they're feeling like they're suffocating. Complications, urinary retention and constipation as a result of the spasm of the sphincter. Respiratory arrest, cardiac failure are late but life-threatening events, and then of course airway obstruction. This only affects the skeletal muscle, so your heart functions normal, your smooth movement is not affected. This is only the skeletal muscle. Your differential meningitis, rabies, tetany due to hypocalcemia, strychnine poisoning, which is like a rat poisoning, trismus due to peritonsillar abscess. Now, I've seen lots of trismus due to peritonsillar abscess. That's just that difficulty opening the mouth. I've never seen that grin like with the rhesus sardonicus, but you may have a patient that can barely open their mouth. And we do see that with PTAs. Your treatment is going to be human tetanus immunoglobulin given intramuscularly. If there is a wound from maybe you stepped on a nail, that needs to be debrided. Active immunization needs to start concurrently. And you have guidelines in terms of if it's been 5 years since you've had a booster, if it's been 10 years since you've had a booster, those types of things, when you're in practice. The treatment is, turn my eyeball. Say it today, gosh, my brain is just on E. That's the preferred treatment. All these patients, anybody that presents with this is treated. Prevention, vaccine, immunization. If you're immunized, you can prevent tetanus. You need to be vaccinated. There is the schedule. I'm not going to text you on that schedule. Boosters are given at the time of a major injury if occurring more than 5 years after a dose. I did have to have a booster in college. I slammed my finger in a file cabinet when I was working at a hospital, and I cut my finger, and because it was a metal file cabinet and we were unsure they gave me a booster at that time. I did not get some. That is your vaccine schedule, just for resource purposes. Post-splenectomy infections. Removal of the spleen had already been established as a routine technique to treat splenic trauma and other diseases affecting the spleen before the anatomy, physiology, and function of the spleen were known in the mid-20th century. What do we know now about the spleen? We need it, yeah. What is it, what does it affect? Our immune system, how we clear out toxins, how, our blood cells is removed, those blood damaged blood cells, So, yeah, we need it. So patients who undergo splenectomy or have undergone splenectomy are at an increased risk of infection. The infections can be caused by Streptococcus pneumoniae, Neisseria meningitis, and Haemophilus influenzae. You don't need to know those necessarily. Overwhelming post-splenectomy infection. This is a syndrome of fulminant sepsis occurring in splenectomized or hyposplenic individuals that's associated with high mortality and morbidity. These infections are characterized by meningitis or sepsis. This is a medical emergency and requires immediate treatment. Death has been reported to occur within 12 hours. Which is the most common post-splenectomy infection? I don't expect you to know this. Does anybody want to guess? Pneumococcus, yeah. Pneumococcus is predominant in the infection of post-splenectomy patients. Neisseria meningitis and Haemophilus influenzae are other common etiologic agents, which I said before. Immunizations against those bacteria decrease the incidence of sepsis, so you want to make sure that your patients who do not have a spleen have been vaccinated for pneumococcus, Haemophilus influenzae type B, and meningococcus, sorry. So we'll talk about Haemophilus influenzae. This is a gram-negative Pathobacillary type bacteria. Group B, a non-typable H1s that can both cause community-acquired pneumonia. Infection is more commonly seen in elderly patients, pregnant women, and smokers with COPD. The onset is a little bit more insidious than that which you would see with like strep pneumonia. But the clinical picture is otherwise indistinguishable. It looks very similar. We see a lot of influenza as a cause of sinusitis, otitis media, bronchitis, epiglottitis, pneumonia, and meningitis. A chest x-ray will often show patchy infiltrates, and sputum gram stain reveals those small gram-negative pleomorphic pathobacillary organisms. Treatments. What are some drugs you might use against H. influenza? Just think about it. For oral antibody treatment, amoxicillin clavulanic acid or augmentin is effective. For patients requiring hospitalization, they may need IV ceftriaxone or cefotaxime. Number of oral antibiotics, including trimethoprim, sulfamethoxazole, azithromycin, fluoroquinolones, some extended spectrum cephalosporins are also active against this organism. Look, I got through the bacteria, yeah. All right, so we have a little bit of time. I do have a HPI, like a history of present illness lecture that I can send to you after we take a break. But I'm going to first talk to you about your ID assignment. So if you check Blackboard, you do have an infectious disease assignment.